Hello, Amir. Nice meeting you again.
Hey,
Yes, great.
can you hear me?
Yes, clearly. Okay. I think now is exact time about today's talk. So maybe we can ask Nina start to begin the talk, and then we can have our beginning. Okay.
Okay, so dear Professor Amir and all participants, good morning and welcome attending this webinar on multidisciplinary research in healthcare. And today we will have Professor Amir to deliver his excellent research experience. And in case that some of you are not familiar with the function of this software website, so I would like to introduce some useful functions to you. So though this is a virtual lecture, so we hope we can have some interaction to each other. Can you first see the smiling face and emoji with a plus sign on the bottom? So please try to click it, and there are a lot of emoji, you can use it. Let's try to practice whenever you want. Moreover, please feel free to leave a question or comments on the chat room, website, at any time. We will collect all the questions and invite Professor Amir to answer them after his speech. So no more waiting. Let's welcome today's moderation, Dr. Tong-Ying Lin, to introduce Professor Amir.
Okay, so thanks, Nina. Okay, so I think it will be my honor and pleasure, not pleasure, okay, my pleasure to introduce Professor Amir Pakpour. I hope that I speak the pronunciation right. Okay. I think that you may not know that, but I have been working with Amir for quite a long time, 5 or 6 years ago. And at that time, I already know that he is an outstanding scholar, and especially in the behavior sciences. And I witnessed many exciting and amazing things that Amir has been done. For example, that he quickly promoted to the associate professor and the full professor and also a dean, and then being, impressed by the Sweden's Jönköping University, and then the Jönköping University wants Emma very, very eagerly, so invite him to become the full professor there, and I believe that Emma will, been doing a lot of research there and also make the scientific world even better and much better. Okay, and actually I learned a lot from Emma regarding some kind of behavior theories or some kind of statistic, although sometimes we exchange our opinions and try to collaborate and try to publish high impact factor journals. But I'm always chasing Emma, as he is always leading ahead of me. And I believe that today our audience will learn a lot from Professor Pakpour regarding how to use the behavioral techniques in the research. And I believe that this will be interest for all of our health disciplinaries. So I think I'm not going to waste your time. And then let's prepare our emoji to give Emma the biggest applause and invite him to give his talk. Okay, and Emma, now it's your time. So I think that you can try to share the screen, and we cannot wait for it.
Okay, thank you so much for a very long introducing. It's my great pleasure to have a short speech here on behavior change. It was my great pleasure to be a close collaborator with Dr. Lin, and of course I have learned from him a lot. And I am, as Dr. Lin, Amir H. Pakpour. I am a professor in 2 universities now. My main university and primary university is now Jönköping University. It's International University in South Sweden. I am professor in clinical sciences there, Department of Nursing. And also I am professor in my own country, in health psychology, in a medical university west of my own country. And also I am a dean of a research institute called Prevention of Non-Communicable Diseases. I thought that behavior change would be a good topic for talking about it, because nowadays we are suffering from lots of problems and lots of health outcome across the world, and it is always nice to know how we can reduce this burden. Very simple and very economic intervention for the population. As you see that pictures, especially from the right one, I have put some figures on order of disease burden. To be called that epidemiological transition, the shift, of course, the shift from infectious and deficiency disease to chronic non-communicable diseases was a unidimensional process. And epidemiologic scientists thought that it is like from communicable to non-communicable diseases. And non-communicable diseases will be predominant and ending with. Anyway, however, it became apparent is that this transition is more complex and dynamic. And of course, we have a COVID pandemic here, and the COVID pandemic affected all of us, and lots of mortal deaths and morbidity, and it is not simple to combat with these communicable diseases. Anyway, from 30 years, from 1990 to 2020, the burden of communicable diseases have decreased dramatically, and you can see that lower respiratory infections decreased from 1st to 6th, and also unipolar major depression from 4 to 2, and ischemic heart disease are not first in this place, and the first cause of death, disability, and morbidity. So this is very important to know that non-communicable diseases is increasing a lot, and it is one sign of behavior and lifestyle. And of non-communicable diseases, around 50%, WHO and some health organization mentioned that most of non-communicable diseases can be prevented, and like 50%, and just using with behavior and behavior change. I believe that, of course, the burden of non-communicable diseases is very much compared to compared to communicable diseases. For example, after 1.5 years of COVID pandemic, we have 4.2 million deaths around the world, but just only for one type of non-communicable cancer. 10 million deaths just only for 1 year, 2020. So this is a good outcome for us to understand that behavior is much more important for shaping our future and affect our outcome. Otherwise, this burden will be increased a lot. If you see Taiwan as a country, you can see that within 10 years, 2009 and 2019, ischemic heart disease kept as first, and 30% has increased its mortality and deaths. So stroke is the second one. Lower respiratory infection is a bit increased, around of lower respiratory infectious or non-communicable diseases. And we can understand that it may be related to the behavior and behavior change. And if we want to compare Taiwan regarding cause of deaths and disability to those other countries, we can understand that Taiwan has much problems with diabetes. Red, orange, and yellow, it means high rank on DALI. Compared to, for example, Canada, Japan, Singapore, Sweden, of course, it's like a comparison with two countries. But I want to say that if you want to think about which behavior is the most important, why we should think about behavior change, you can see these statistics as a justification of working on behavior and behavior change. A pattern and behavioral and risk factors for deaths and disease in Taiwan until 2019, you can see that we have three metabolic, environmental and occupational risk, and behavioral risk. These categories are interrelated. And I mean, for diabetes and high fasting blood plasma glucose, we have a risk, but we separated them to be more clear and to be understandable for readers. Anyway, if you see, tobacco is the first for behavioral risk of so many diseases, and it is increased around 10% until 2019. And it shows that this is the first behavior should be changed in Taiwan, for example. And of course, in other places, WHO warned that worldwide spread of the tobacco epidemic could claim 1 billion lives by the end of this century. So this is very important to know that we need a good thinking about behavior. We need to know that which behavior would be more important based on statistics. It's like a need assessment, health need assessment, and we should design an intervention, a good intervention for otherwise we cannot be successful to reduce the burden of diseases. And this is, of course, a multidisciplinary area. If we want to think about behavior, we should think about outcome of behavior. As I told you, health is the outcome of behavior. We behave to be healthy, and health is like a philosophy of life for everyone. And if we want to change someone's health, we should change person's philosophy of life. Philosophy of life means attitude toward meaning of life and way of life. So you need to change this from value, social networking, and social support. So many requirements to make people healthy. In that case, we will need to have a good intervention on several levels. We call it social levels. In health psychology, we have 4 levels. Of course, these are related to the people. First of all, and the simplest and maybe very easiest way is working on individual. We can blame individual for being physically active. We can blame them to adhere diet and other behavior. But this is not enough. And our intervention won't be permanent and keep it for a long time, because we need a supportive environment. And if we want to work only on individual, we are lacking environment intervention, and we need supportive system and supportive environments to keep individuals change in a good way. So in the next level, it's a group. Please don't forget, so many studies are working just only on individual, and they are not working on other social levels of intervention. And that's why our behavior is increasing across time. I mean, unhealthy behavior, and we can see it. They are the main reason of non-communicable diseases. In the group, you can see that we have one element of environment. It's called social pressure. It's called culture. It's called custom. And in that case, we can shape significant others for this group. So more, if someone's recommend to do this behavior and if someone's approve this, and now we are shaping in a better way from individual. And the next level is organization level. The several groups can shape organization. And the organization, we have some other elements and sub elements from environment. We have law, regulation, and policy. It is very important. Let me give you some example. Of course, one example from Jönköping University. When I started working as a professor in 2015, the Jönköping University, the university dean recommended me to start and work with employees' health. First, we started some qualitative study to understand which part of health is damaged and more important for this person as an employee in the organization like a university. I found that the diet is not good at working and they are not eating fruit and vegetable as much as enough. So if I wanted just only work as an individual, I could develop intervention and blame individual and say that, yeah, you can eat a lot and keep your diet healthy. But it is not enough. We need to have a good supportive system. We started some negotiation with first those who are take the responsibility, and we provided fruit and vegetable weekly for each department. And we try to have this support beside to the or intervention. So the employee in rest time, it's like we call it fika time in Sweden. They have had 30 minutes 2 times in a day to go to the fixed room, like the restroom, and consume coffee and drink water, whatever, and also fruit and vegetable. And it was very successful because the organization shaped this rule. And also, if you want to think about physical activity for employee and other people, you can understand that regulation and policy needed for this. Otherwise, we cannot be successful. I mean, for the organization, it should be a law in some organization. Employee have to exercise in the morning and then start their working. So they will be fresh, healthier, and then they can be much more successful in their own jobs. Anyway, the best one and the complete and the good behavior change intervention in social level is community. You have culture, you have law, you have policy, you have environment, you have general population within patient and other types of health problem. And if you want to be successful, this is the best one. But of course, it is not that easy. We have had the chance to do this in my country, in the city I'm working as a professor in Kasvin. In the waste management, it was not that good. Recycling behavior was only 10%. And we started working what was the main for very low recycling. And we tried to do some qualitative and quantitative studies to understand what is the main reason. And we found that we need a good and supportive environment for the people in general population. We provided them some trash bin for each building, and we educated much for them, and then we provided some fee when they try to separate solid waste. Now it is still working after 7 years, and the recycling behavior is now around 70%, and it is very much good for this, because we started with municipality and working with the community, and this will help, of course, for the whole population. Let me to define the behavior, and it is always good to know that what is behavior. We have two scientists, and these two scientists have worked on some aspects of behavior, and they have defined behavior on their own. First is Parkinson. He defined behavior as action in social levels. I mean, individual, group, organization, and also community can improve coping and quality of life. This is good start, but has problems, because action should be defined. What is really action? What is action exactly? Dutchman tried to define a better one, but only for individual. He defined behavior as an action, observable, overt, and also measurable. These are one of the most important aspects of behavior. And if you want to define behavior, I have defined behavior in my own also from the stimulus response theory, and it's like this. And I defined this behavior as a response of the organisms to various stimuli. I defined it behavior as a response of organism to various stimuli. The stimuli could be conscious, subconscious, overt, covert, voluntary, and involuntary, and of course measurable. Here in medical and health sciences, conscious, subconscious, and measurable is the most important aspects of behavior's definition. So we need it. And if we can define in a good way behavior, we can measure it in a best way and design a better intervention for them. Hope you are still with me. Can you hear me?
Yes, yes.
Sorry for asking a lot, because I am in. Okay. Now we can understand that we need learning, we need to response, we need some aspect behavior to design a good intervention. I should mention here there is a very huge differences between conscious and subconscious behaviors. Conscious behaviors is new behavior that you are trying to adopt it, and when you want to try to adopt it, it is still in your conscious area. And if intervention could be good, you repeat and exercise a lot for a long time. Francesca said that it takes around 6 months to transit from conscious to subconscious. Conscious behavior, give me an example about conscious and subconscious. When you start driving as a new driver, you sit in the car, turn on the engine, and try to driving. And first stage, you have to stick the string little and very nervous. You can not see mirror in a good way, and you are in a very stressful situation. If your mobile ringing, you will be much more stressful, and then it takes much time for you, and you have to think for every activity you want to do, and the burden is much more for you. Practice, and it takes more time, then this behavior will shape as a subconscious. In the subconscious, it is habit, a routine, and you do it without thinking, and you do it automatically. You don't think it much. When you are a good driver, you just only drive it and don't think much about driving behavior, and you do it. So this is very important. If you want to design a good intervention, you should try to do an intervention which lasts at least 6 months to transform from conscious to subconscious. Of course, it needs lots of activity and lot of work, and it is not simple to do that. Albert is. Are you with me?
Yes, we're with you.
Sorry. We are now know that behavior comes from learning, and learning it's like partly permanent change of our potential minds. So, if we think about little Albert study, it is about 1920 by John B. Watson. It's like a classic conditioning. It's like trying to behavior in the very simplest way, and this conditioning, of course, won't last for a long time, and it will be decrease across time. But the white rat neutral stimuli show to the Albert no response, unconditioned stimuli load noise showed to the Albert and produce fear response. Fear response is very normal, unconditioned response, and then unconditioned response and neutral response happen together, and then produce still unconditional response. And at the final stage, we have white rats just only and produce conditioned response, and white rat is conditioned stimuli. This conditioning, classic conditioning, can be used in very problems for treating problems, psychological problems, those who are anxiety and other things can be used, and you can use this, but it is not enough, and you lots of updated intervention for it. We are still using operant conditioning like reward and punishment, and if someone reward to us, we see it this behavior as a strengthen. So this is important to us to understand that conditioning can shape behavior, but it is not a permanent behavior, and it takes a lot of time to shape it in a good way and permanent way. We have 3 types of behaviors. I think that some nurses are audience of this session. These behaviors, of course, help us to understand patients' behavior. The first behavior is preventive behavior. I should mention that this category comes from Castle and Co. from 1966 to develop a good intervention for those who are not compliant to the treatment. Preventive behavior are those behavior which we are taking to avoid vaccination. And illness behavior is a symptom and subjective feeling of behavior, and it's like a pending illness. For example, pain, for example, not feeling good, it's internal, and people cannot observe it. But it is a good start to think about if you are ill or not. And sometimes you are depressed or at this step and this category, and they need to have a good intervention to shape them from illness behavior to sexual behavior. Sexual behavior is the last category of health-related behavior which someone try to accept their role as someone who will be ill. For example, diabetic patient who accepted, I am now diabetic, I have to compliance with treatment. So if we in the illness stage, I mean illness behavior, then maybe parents do nothing, or maybe self-treatment, and in a very rare condition they will go to doctor and compliance. And just wanted to stress that one of good intervention in the medical setting is to help patients to accept their role as a sick. Most important things in the behavior is measuring. We have two types of measuring behaviors. One of the most important, very easy, is self-reported measure, and another one is objective measure. And studies has shown that the correlation between self-reported and objective measure is not that much, and then we need to use both of them, especially when we are living in some countries, especially in Asian countries, with social desirability and with high social desirability. I mean, social desirability means that people would like to pretend themselves in a good way. And if you ask patients if you are taking your pills on time, some of them say that yes, but it is not true because they want to pretend themselves in a good way. So self-reported measures should be combined with the objective measures. Of course, we cannot use objective measures a lot because it takes time, lots of money, and it is not possible. But anyway, it is important for us to know that self-reported measure is not enough, and we need objective measure in our RCTs and in our studies, and we should add this aspect to estrogens or result. The definition of a given behavior is also important. Some studies has done, for example, across so many countries like United States and UK, they are all using a similar definition. For example, for the physical activity, for smoking, but there is still not a well-defined and agreement on some behavior like diets. And if you use a different definition of a given behavior, you cannot compare your result, and it will be problematic, and you cannot be a good stand for future study and comparable study. So Center for Disease Control and Prevention in the United States is trying always to define and use in its cohort in a good way to understand the patterns. And it is always important to use the best references, the best definition, for example, for physical activity and how we can compare these out. And in that case, you can see the change across time in the future. Now we are approaching to a very important why we think that behavior should be changed. First of all, I showed you some facts. I showed you what is different behavior, and now I want to say that if we want to change the behavior, we need theory. Almost 50% of all study have done without theory, and their effectiveness is very vague, and they are not much successful. Of course, we can do an intervention without theory, but there are so many reasons to use theory because human behavior is a psychological aspect and it's also social aspects. And theories use both social and psychological factors to predict behavior. And behavior, you know that it's very complex and you cannot only use a simple intervention without any theories and prior knowledge about it. Theories has been associated with a more successful outcome. Thomas L. Webb has done a systematic review 2010, and they found that those studies with theory and based on theory have been 4 to 10 times more successful than those without using theory. So using theory, it's a like map. You can find your home maybe without map, but with map, you can save your time, money, you can understand more, and using theory, you can understand the cause of problems in a good way and mechanism of change, and will be much more successful, of course. What is a theory? Are you with me still? Yes. Dr. Lim?
Yes, yes.
Sorry for asking again. Yeah, what is theory? Theory is like abstract concept or explanation of the world and the fact which is happening in the world. And with theory, you are showing the concept from the world and trying to find the relationships between the concept to have a scientific justification. And in the theory, we have 3 elements: the concept and the construct, and later one is variable. And the concept are the major component of the theory. They are building blocks or primary elements, and they are very abstract level, and they could be very general. And when we use concept, real theory, we are shaping it to the construct. So construct is like concept, but is using in theory. And of course, construct is still abstract, not directly observable, because it's like love. How you can measure love? Love, if can be in the theory, and if you have a measure, and if we call it variable, then we can use it. And we can call it as a measurable variable. Then the last element is variable. And when you use construct in a very specific situation like a physical activity, now you are shaping a transition construct to variables. And we can use it in several situations. We have lots of theories and lots of models. Here I would like to have some explanation about differences between theory and models. Models is a physical and verbal or mathematical or maybe graphical representation of a concept or an idea. Model can include lots of theories. For example, health belief model can use 3 to 4 theories to shape it. Model is macro level, it's a bit general and a bit simple way of a theory, and theory is very focused and micro level, and of course complex. So when we call model, we are using several theories, and it is much easier to use models because you can develop it in a easier way. But when you want to develop a theory, it is much more tough, and you have to think about very micro, and it is not possible to change theory very arbitrary and individual. And we have lots of models and theory, like health belief model, social learning theory. Health belief model has been used across time, and it is still using. For example, in COVID, we are still using social learning theories, and social cognitive theories also using true planned behavior, which Fermat was terrorism reduction is still using. Of course, true planned behavior is much more to be used. Trans-theoretical model is a very interesting model for addictive behavior, and social support and social network is also using, and social marketing is much frequently to be used now. So we are lots of theory, and theory are so many, but the first things we should know about behavior. What is the definition of your given behavior, I mean physical activity? What is the real situation physical activity in the country, in the target zone? And how we can use a theory for solving your problems. Sometimes you have to think a lot and discuss a lot why we want to use theory of planned behavior. So sometimes we cannot use without a good and a strong reason a theory. So it's important, and I really recommend to think and to do some preliminary studies to understand which factors is most important to use and for behavior, and then to use your theories. And for example, in true planned behavior, it's like a psychosocial. If you don't have a social problems, you can use, for example, health belief model or TTM. Or for example, if you have very social problems, you can go to social cognitive theory. It's like self-efficacy, learning, it's observing. I want to say that selecting a proper and a good theory is really tough, and it depends on your problems, and it depends on your real situation. I mean, it needs so much discussion, and then you can use it. Within 10 minutes, I want to talk about very earlier model, health belief model, to be a like example. I understand that this session won't be a perfect session to talk about several theories, but I just want to start with a model to understand how we can use HBM or a model of theory in real life. HBM is the model to be used in very old 1950, and it was an attempt to explain why only a proportion of US population agreed to undergo to a screening test, X-ray test, for lung cancer. It was very uncommon that time, and people understood that it is free. but they didn't. So researchers tried to develop this. It is still using, of course. Assumption of the model backs to 4 and 6 elements. People can take the behavior or change the behavior if they personally susceptible, they believe that they are susceptible to a disease, for example, lung cancer. The outcome like lung cancer is moderate or severe. I mean, maybe they passed away, so well, it is very serious situation. So if they can understand and perceive that if they take X-ray, it will be benefit for them and the risk will be reduced. And other component and assumption is that perceived benefit should be much more than perceived barrier. There is 6 construct of health belief model. We call it construct because we are not using in a specific. If we are using for X-ray and screening, now we are calling them variables. Perceived susceptibility, it's like belief that a person may acquire disease or in a harmful state as a result of a particular disease. Perceived severity is belief in the extent of harm that result from acquired disease. Perceived benefit, it is also beliefs in advantage which a person can get. Perceived barrier is, of course, actual, maybe could be actual or imaginative, that it's concerned that the new behavior will take too much time, too much pain, too much money. Calls to action is a force that would make a person need to take action. Those supports, for example, radio, internet, and also these are external. Internal could be pain as a cue to action. And self-efficacy was added later on to this model, and it is not the original construct of the health belief model. It's added during 98, and it's confidence in the ability to successfully perform a behavior for a specific outcome. This is showing the picture of health belief model. It's a construct, and we have, as you can see, that self-efficacy is not mentioned in a very specific way, and we have this construct as it is. And I have example for the HPM for the COVID vaccination. Perceived susceptibility is how likely it is I will get COVID-19, and how much people believe that if they get COVID-19, and perceived severity is that how bad would be if they get COVID, and perceived benefit is what do I gain by getting the shot, and perceived barrier, what do I lose by getting the shot? For example, losing time, losing money to go to the place for vaccination, other things. How cues to action is friends and family express support to benefit of the vaccine. And if they do like a rule for us, it will be easier for us to vaccinate. And of course, I have another example. I think that I should go to another slide. I can for you, and you can use this for your own reading. HPM has lots of weaknesses. The studies has shown that there is not good for long-term behavior. The definition long-term is more than 6 months. So several studies have shown that it's not good for long-term behavior because it is based on fear. And if fear is disappearing, the adherence to the behavior will not be much. The predictive power, not that good. For example, despite that meta-analysis showed that it's positive as statistically significant between construct, but the variance is not that good. It's around 1% to 9%. So I believe that this is very big weaknesses, and it is also difficult to be tested. Sometimes we don't have a valid measure, and it's very old-fashioned, and we only want to focus on fear and perceived threat. It won't be a good design for us for developing intervention. And I showed you this meta-analysis to know that, to understand that HPM has still can be used, but it is lots of problems. And as a conclusion, if we want to change behavior, a given behavior, we need to have a strong and positive intention. We have environmental support, and shouldn't be environmental constraints. I mean, like social pressure. People should shape their skill. People should believe that taking this new behavior has been a great advantage. And in the formula, it's perceived benefit minus perceived barrier. And if the result is positive, then you can make sure that this will be, people believe that it is advantage. And it's like environmental pressure and social pressure and social norm and pressure is that other people recommend to and accept new behavior. And the new behavior should be consistent with our personality, and we saw ourselves someone, for example, be physically active, athlete, and whatever. It is important. And also, when we do this behavior, we react positive rather than negative, I mean emotional. And also, we have a good capability to perform the behavior in different circumstances. For example, if you want to keep your diet, you should keep your diet in the party, when you have an exam, when you are at home, when you are with your friends. So this is self-efficacy. I can show you some very, very brief talking about behavior change. If you want to read further, I have recommended you 4 books to be used. The last one, the Handbook of Behavior Change, has published recently, and the first editor, Martin Sager, one of the biggest and leading. Please don't forget that designing an intervention based on theory is not easy. Sometimes you need intervention mapping. You have to start from qualitative to know that which variables is the most important, and then come to the RCT. And also, please make sure that you are measuring behavior change for a long time, like 6 months, to understand if intervention can work for a long time. And it is always good to consult with health psychology and behaviorists before starting and measuring behavior and designing your behavior. Thank you so much for the possibility to talk with you all, and I am here to answer to your questions, and thank you so much.
Okay, thank you, Amir. Thanks for the fantastic talk. Although there are some connection problems, but anyway, I think for the second half of your talk is smooth, and I believe that some of our audience may have some questions want to ask you regarding the behavior changes. So now may I know if there's any audience wants to ask question to Amir regarding the topic, behavior change. I think this is a big topic and many questions may come out. Okay, seems that they are still digesting what you have been delivering. But meanwhile, because we have asked our participants if they have some ahead questions, they can post on the registration site. So now we have some questions that have been asked ahead of this presentation. So I think maybe I can start with these questions and let our participants should have more time to think about what you want to ask for Professor Pakpour. So the first questions that I have is to explore whether multiple behavior variables, for example, like self-efficacy and motor recovery in stroke, simultaneously contribute to a dependent variable. For example, ADL performance, activity of daily living performance. Is it most optimal to analyze phenomena as interactions in regression analysis? If not, what would be the more appropriate method?
Thank you so much for this question, of course. You know that I'm not really good at the occupational therapies, but as far as I understand, motor recovery and ADL are like outcome and behaviors, isn't it?
It's how you do your activities in your daily living.
Yeah. Activity daily living and motor recovery is also like it's the behavior as well. So I believe that you cannot have an interaction between self-efficacy and motor recovery.
Emma, sorry, may I clarify a little bit? The motor recovery is more on the neural side. That is, our brain control our movements of our hands or our yes, our foot.
Yeah. I understand that. So sorry. That's why I. Yeah. In that case, yes, you can of course using because self-efficacy is beliefs and several studies have shown that when you have much self-efficacy, you can perform a behavior in a good way and more accurate. So this is very clear that you can use an interaction between motor recovery and self-efficacy can help simultaneously to performing daily. Yeah, you can use this.
Okay, great. Thank you.
It's like trying to shaping the behavior from conscious to subconscious. When you are trying to interact motor recovery with the self-efficacy to activity daily living, and you want to do this. And if we found a good interaction and a strong interaction, it means that people who have a higher self-efficacy and motor recovery will have a good activity daily living, of course.
Perfect. Okay, so thank you for this answer. I'm not sure whether the person who asked this question want to ask a follow-up question. And I may continue my other questions to save time. Okay, so here's the second question. That is, in the study of lifestyle interventions, how to assess the changes of habits and routine in addition to specific behaviors, for example, like exercise or diet. Is there any suggestion on this methodology?
Yes, if you remember, I talked on my lecture. Of course, when you are trying to change your behavior from conscious to subconscious, you are trying to develop a great intervention. Of course, this is very important. There is a there are two ways for measuring habit or routine. The first way is past behavior. It is much more easier to be used, just only with some question or maybe one question, and you can ask routines routines activity, like in the past months, how much you have been active, physically active. Or you can use a scale. It is also like Benjamin Gardner developed it. It's SRBAI, self-reported habit index, and it is talking about ability, about all behavior, and you can use your own words in this scale, and it's much popular scale and have been used before, and you can see future behavior and the correlation between past behavior or SRBAI. But you cannot use both of them. It's not add anything to the literature. Just only select one of them because both of them are like a habit.
Okay, got it. So here's one more question. That is, there's a participant says that he or she uses the Anderson model for the research framework and longitudinal study design for measurement health-seeking behavior among adolescents pregnancy with complication of pregnancy. So, is it possible to measure the changes of health behaviors among them?
First of all, thank you so much for this question. Anderson model has been developed in 1995 it's like a behavioral model, access to medical care, and it's interesting model to. It's like triple behavior, HBM, and other theories to predict consumer using satisfaction and etc. Of course, you can use a longitudinal study. Several studies have done before and show that, for example, I've used this model before, and then they used telephone interview to know that if people and participants have used the medical care or not. Of course, we can use, and you can say that how it is changing across time. And I saw some studies, for example, in the UK, they have used some telephone interview with people every 3 months to know that if people are using mental healthcare system and across around 2 years. So I think using a longitudinal design could be much more informative to know that which factors could help for approaching and using medical care. So this is very interesting study and should be, of course, with this model for health-seeking behavior.
Okay, thank you. And may I know if there's any audience or any participant have further questions or some comments exchange with Professor Pakpour?
I understand it's a bit complicated topic, but it is interesting, and I know that you try to use proper and correct measure and develop it in a good way and design it, maybe online or face to face, it will be very interesting for you because it's related to our lifestyle and daily living, and we are all having behavior and we have to change even our behavior, like cell phone addiction, for example.
Yes, here, Emma, we have one new question. Okay. The question is, what is the differences between preventive behavior and illnesses behavior?
Could you please repeat what?
What's the difference between preventive behavior and illness behavior? As illness behavior seems to be health-related behavior.
You mean preventive behavior and illness behavior, you mean?
Right.
Yeah. Sorry, because the voice is unclear sometimes. Hope you can hear my voice in a good way. As I mentioned, preventive health behavior, it's those behavior before illness. It's like vaccination. But illness behavior, it's those behavior which you are starting feeling not good. It's not preventive now. It's now you are within and with your disease. And maybe the disease started with feeling not good, like catching cold, COVID, and then you will search and seek your treatment or not. So this stage is very important, illness behavior, because it's subjective and you finish it with self-treatment, or maybe you go to doctor and accept your role as a sick person, or maybe if after some medical test you find out that you're not feeling good is not related to your disease and it's general, it's not, and you are healthy. So in that case you can turn on to preventive behavior. It's very early, and then we have illness behavior when we are starting with the disease, and then when we accept or rule, and then we want to cope and we want to try to improve our health as a sick person, then we call it sick rule behavior.
Great. Thank you for the clarification. And here's more questions.
Can you
Hello?
hear
Yes,
me?
can you hear me? Yes, we can hear you. And now here we have more questions coming. Okay, so here's another question is that, can you talk more about the theories, models, variables, which are related to the enhancement of intrinsic motivation for maintaining physical activities? Hello, Emma? Can you hear me? Hello? Hi, Emma. Okay. It seems that now the connection is dead again. I'm checking with Emma now, but it seems that, okay. Because we have only one question left, okay? So if Emma cannot come up, then I may pass the question to Emma and let him answer it in words. And then later, when we post our, we have a page in Facebook, and we will post the this talk information on the Facebook, and we can give the answer at a time as well. Okay, it seems that Emma really have some problem in the connection. Okay, so thank you again for coming to this talk delivered by Professor Amir H. Pakpour. And there's more questions. Okay. Anyway, if you have questions, you can leave here, and then I will ask Emma to answer them by words. And then later we will post it on our page in the Facebook. And then so later on, you may go to our page and to see if your answers are there. Okay. And can Nina, can you help to post the page of our Facebook to our audience? Then maybe later, if they want to see their answer or to want to review this talk, then they have the chance to see it. Okay, and before we towards the end, then we may invite our director, Professor Hui Wong, to give some words to you.
Oh, hi, everybody. Thank you for all of you participating in this online series. I'm very grateful for all of you participation. 我想我们现在这个演讲这次做的蛮成功，就是刚开始有一些连线的问题哦，那跟大家报个歉。那我们现在已经准备要结束。那如果各位还有其他的问题，就是可以到我们的网站，那这边呢有我们的社团，您可以在这里留言。那我们未来在这个学期的11月、12月还会陆续有几场也是跨域研究的线上演讲，这样子。好，非常谢谢大家，我们也会把感谢的部分呢，就是也会传给 Emma 教授。好，谢谢大家，我们会议正式结束。
Thank you. Thanks, Director Wong, for giving the closing remarks. Okay.